One moment, everybody. I am going to share our before we get started slide. All right, everyone, welcome to our TMA webinar for the day, Unlocking the Potential of CAR-T and Myositis Advances and Insights. Before we get started, disclaimer, TMA does not give medical advice. Our educational webinars are informational, and we encourage you to make all decisions in your care in partnership with your healthcare team. TMA is very grateful for our expert speakers from all over the world, and we ask each speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel on the 1st of next month. And please, in the chat, let us know where you're tuning in from. We love to see how far this community reaches. So please put any questions you have in the Q&A box. Pre-submitted questions are being loaded into Q&A by TMA staff. Questions put in the chat box may be missed. TMA evaluates its programming to ensure we are meeting the needs of the myositis community. A survey will pop up at the end of the webinar, and we ask that you please take a few minutes to provide input to inform future programming. Thank you.
So welcome to today's TMA webinar titled Unlocking the Potential of CAR-T in Myositis, Advances and Insights. We are thrilled to have you join us for what promises to be a highly informative and insightful session. My name is Tania Gonzalez, and I'm the Head of Medical Affairs at Cabaletta Bio. As a sponsor of today's webinar, we are very proud to be part of this conversation about the exciting progress being made in the field of CAR-T and the potential for treating myositis. Before we get started, I'd like to take a moment to thank the Myositis Association, Rachel, Paula, Linda, everyone at the Myositis Association for hosting this important event, and to express our gratitude to the most important people, all of you, our attendees, for your ongoing commitment to learning more about myositis and the advancements in treatments. We're incredibly fortunate to have with us today Dr. Iazsmin Bauer Ventura, a leading expert in the field of rheumatology and myositis, to share her expertise and insights. Dr. Ventura is a passionate clinician scientist who specializes in providing care to patients with autoimmune diseases, specifically myositis and autoimmune-related lung diseases. She's a faculty member at the University of Chicago, where she serves as the director of the Myositis Program and is also part of the multidisciplinary team focused on treating interstitial lung diseases. Dr. Ventura recently served as the TMA's board of directors, and we're thrilled that she's here today to discuss the latest developments in CAR-T cell therapy and how we can impact myositis treatment and outcomes. In addition to her academic career and clinical expertise, Dr. Ventura is currently our principal investigator for Cabaletta's RESET clinical trial at the University of Chicago. Her work is helping to pave the way for new innovative treatment options for those living with myositis. We're excited to hear her insights into the role of CAR-T and the promising future of this therapy. Without further ado, I'd like to hand it over to Dr. Ventura.
Gracias, Tania. That was a very nice introduction. Thank you so much. It is really a pleasure to be here this evening with you all. I'm gonna get started because we have a lot to accomplish today. And again, I appreciate everyone coming here, spending an hour of their evenings to be here with us today to talk about a very exciting topic. So we're gonna talk about CAR-T. And I am, again, as Tania mentioned, very lucky to be a principal investigator for the Cabaletta's CAR-T clinical trial in myositis. I am the director of the Myositis Program at the University of Chicago, and I am very privileged to spend most of my time in clinic caring for patients with myositis and interstitial lung diseases. So thank you so much for having me here today, and let's get started. So quick outline about what we are going to discuss today. I'm going to talk a little bit about the biology of myositis, specifically about a cell called B cell and also T cells. And I'm gonna ask you to be with me doing those more fundamental slides, because they're gonna be really helpful later on to understand how the trial develops and why this trial is so exciting. And then we're gonna talk specifically about what is an actual CAR T cell. It sounds like a weird kind of nomenclature, and I wanna explain to you what it means. And then we're gonna get into more details about the trial per se. Are you a potential candidate? Do you know anyone who could be a potential candidate? So those things will be discussed in the end of our presentation today. And then we're gonna open up for questions. Okay, so let's talk about B cells in myositis. I don't need to tell you, I don't need to teach you the burden of myositis to one's lives, one's families, and also to the world in general. So even though it's considered to be a rare autoimmune disease, the incidence of myositis is increasing all over the world. And we know that the myositis, even though the name kind of focuses on the muscle involvement of the disease, we know it affects virtually any organ. So patients with myositis have cardiovascular manifestations, pulmonary manifestations quite often. They have arthritis, they have rashes sometimes. And myositis can affect anyone. It can affect very young children, can affect older adults, it can affect people doing the young adulthood. So it really is a very democratic disease in that sense, that it doesn't spare anyone. And as you know, it is a disease that is quite difficult to treat a lot of times. Patients can fail several different kinds of treatments. And unfortunately, a lot of times it is a try and error situation until we find out the right treatment for a patient with myositis. Okay, this is the moment that I'm gonna ask you to hold on with me, and I'm gonna rescue a little bit the knowledge that you have about cell biology from school. And I promise again that it's gonna be really worth it. So here on your left side, you have very nice pictures of blood cells. Okay, so these guys here on the upper side, they are, and also macrophages, they are immune cells. So they're part of your immune system. And their goal is keeping you protected from infections, viral infections, bacterial infections, fungal infections, and also they are very helpful in protecting one from cancer too. So these cells are really, really important for our immune system. And we have here also the red blood cell, erythrocyte. This is the one that carries oxygen and carbon dioxide through our blood. And also we have platelets that help us to producing clots that prevent us from bleeding, okay? So now moving to the right side of the screen, I wanna mention and wanna explain a little bit what this chart means. So right here at the top, you had the blood stem cell. So this big cell lives in all of our bone marrows. And this stem cell, it is basically the parent cell from all these other cells that populate our blood. And as you can see, from this blood stem cell, we have other cells differentiating. So we have specific families that come from this blood stem cell. It is really important to acknowledge if each one of this family, again, has a function in our blood, it has a function in our immune system, and each one of this family has a last name, has a surname, has a thing that differentiate that family from the other families in our immune system, in our blood cells. Okay, so each one of these families again have their last names or their markers that live in the surface of these cells, and these markers help differentiating cells from different families. The same way that my last name is Bauer Ventura, and that's how I differentiate myself from others, is because of my last name. The same happens with the cells. They all have specific proteins on their surface that tells them from which family they are from. Now we're gonna focus a little more on these cells, this family of cells called B cells. B cells are lymphocytes, again, coming from the stem cell, a part of our immune system. And we believe that these B cells that you can see here in the middle of this picture, these B cells are very important to the pathogenesis of myositis. What I'm trying to say is that we believe that these B cells have an important role in the development of autoimmune myositis and also other autoimmune diseases as well, such as lupus. So these cells, traditionally, they are supposed to produce antibodies, proteins, that again, part of our immune system, keep us protected from virus, bacteria, etc. These B cells also interact with other cells in our immune system, and that interaction leads to the immune response that we need to develop when we're infected, for example. Unfortunately, in patients with autoimmune conditions, and I'm talking more specifically here today about myositis, these B cells, they seem to be reacting not against a foreign antigen such as a virus or a bacteria, but these B cells are autoreactive, meaning they are reacting against our own proteins. That's where the autoimmunity is coming from. So by reacting to our own proteins, these B cells are producing antibodies against our own proteins. And we believe there's great data most recently being published that these antibodies have a role, a pathogenic role in how myositis develop. These B cells also, when they are autoreactive, they orchestrate our immune system against our cells, causing inflammation in many of our tissues, such as, again, the skin, the muscles, the lungs. And unfortunately, these B cells also lead to the secretion of cytokines, which is a fancy term for chemicals that enhance inflammation. Because of this data showing the importance of B cells in the development of myositis, we believe that targeting B cells specifically could be a very interesting way to control myositis and treat myositis. Okay, remember I mentioned to you that every single cell in that lineage comes from a family, and that each one of these families have specific last names or specific proteins in their surfaces that helps to differentiate them against other immune cells. Well, that's the case about these funny things that's spiking over the surfaces of the cells. Those are CDs, which stands for cluster differentiation, which is, again, it is a protein in their membranes, in the surface, that basically tells from which family the cell is coming from. So all these guys here, they have the CD19 cluster differentiation molecule or protein. They come from, again, the B cell family. And as you can see, the B cell family, they have folks who are babies, very small, and then mature. And then they have specific roles depending on how mature they are in their family. So things evolve as they get older in their family line. And again, but as you can see, the CD19, these specific proteins, continue to hang on to their membranes throughout their lifetime. And these proteins are important not only to help us to understand where the cells are coming from, what is their family, but these proteins are also extremely helpful in the interactions between cells, immune cells. So these proteins are telling, hey, I'm from the B cell family, and these proteins are also helpful in the interactions between cells in our immune system. So our cells interact through these proteins there in their membranes. And here you see in these squares, in these boxes, different medications that target specific molecules. So pharmaceutical companies have for many decades already been manipulating the way different medications interact with these membrane proteins. And by doing so, we are hoping to, again, kind of block the activity of these cells and therefore leading us to better disease control. So most of you are familiar with a medication called rituximab, very often used for the treatment of myositis and other autoimmune diseases as well. So rituximab target this other guy here, the CD20, which is, again, with the hope that the CD20 blockage will be able to cause a B cell that is, again, autoreactive to be dysfunctional and not cause all that inflammation that we believe is related to the disease activity in myositis. Okay, moving on. Now that we talked about B cells and we have a better understanding on why do we think they're important in the development of myositis, I want to talk a little bit about what cell therapy means. Cell therapy sounds like a very fancy term, but actually we have been using cell therapy for, I would say, 100 years, because the most common use of that cell therapy actually is blood transfusion. And blood transfusion started to be a practice right around between the First and the Second World Wars. So it's been 100 years that we have been using cell therapy. Other example of cell therapy is IVF, in vitro fertilization is also a type of cell therapy. So what do we mean with cell therapy? Cell therapy is the use of our own cells to treat conditions, to treat diseases. And that's the case with blood transfusion. Someone is anemic and he needs red blood cells. We transfuse red blood cells from a donor to someone who needs the red blood cells, for example. There are two different kinds, mostly, of sources of cells or cell therapies, I would say. One is the autologous, when I'm using my own cells to treat the condition I'm interested in. For example, if I'm dealing with infertility, I can use my own eggs to be fertilized elsewhere and to treat my own infertility. So that would be, I would say, an autologous use of cells. And we also have the allogenic source of cells, in which we use donors, and these donor cells are infused using someone else to treat their condition. And again, this is usually the case with blood transfusions. So I just want to, again, get the idea that cell therapy is something very new and modern and we don't know about it. That's really not the case. We have been using cell therapy in different ways for more than 100 years already. All right. So this is a close view about that CD that we're talking about, that last name that it is this molecule or this protein that hangs out in the membrane of our immune cells. So here we have a cross section of a T cell, another immune cell that we have in our blood, in our immune system. And one of the most common proteins that it is in the membrane of T cells is the CD3, for example. CD3 is one of their last names. And this is one of the membrane proteins that we use to identify T cells. So this membrane, as I mentioned, this membrane protein, as I mentioned to you, is not only important to understand where is this cell coming from, which family does this cell belong to, but also this membrane protein helps this T cell to interact with other cells. So you see here, this blue molecule here is the protein. It is the receptor of another protein. So remember, those CDs, they help us to identify where the cell is coming from, but also for the interaction of cells. Okay, so this is the T cell, the CD3, which is normal occurring in all of our systems. Now, let's move to the right side. And we have here the chimeric antigen receptor. This fancy term, it is the CAR that we talk about when we're discussing CAR T cells. So basically, what Cabaletta is doing, for example, it is that it is hardening these T cells and adding to the membrane another type of protein, another type of molecule. This green guy here, it is basically the product that we are talking about here with CAR T cell therapy. So this protein is inserted in these T cells, and these proteins are gonna now react differently to the receptors of other cells, particularly in the case of our clinical trial, to the receptors of the B cells that have CD19. So again, what this clinical trial is doing is hardening the T cells and then adding this protein here in their membranes, and this protein is going to interact with the CD19, again, the membrane molecule of the B cells that we believe are pathogenic in patients with myositis. So hopefully, again, all the cell biology discussion made sense now that we can visualize what is the difference, what actually happens when a patient get their T cells to be weaponized, to be re-engineered to fight against autoreactive B cells. Okay, now what are the procedures related to this CAR T cell clinical trial? So in general terms, a patient with myositis is identified as eligible for this trial and is enrolled, sign the consent form, goes over a bunch of educational materials with their physicians in the centers where they're having the clinical trial. And then this patient goes through a process that we call leukapheresis, which is basically a blood transfusion. So this patient had a line placed, and then the blood is filtered to collect T cells. Remember, T cells are going to be our agents against the autoreactive B cells. These T cells are then transferred to the lab from Cabaletta, and these T cells have this CAR membrane protein. Remember, this green guy here, it is inserted in the membranes of these T cells in the lab. After these T cells have been again re-engineered in the lab, they go through proliferation. We want as many as these soldiers as possible. And these cells are frozen until the patient is ready to receive them. What do I mean ready to receive them? So just before having those T cells re-infused in the patient, again, we are talking about one single patient and all the cells are coming from the same patient. The patient needs to go through a session of preparation or chemotherapy. This is a dose of cyclophosphamide and fludarabine, and this is basically a primer. This is a way that we allow the immune system to accept, to receive this new re-engineered CAR T cells, okay? So this is the preparation phase. And after patients go through the preparation phase, they have these CAR T cells infused as part of the clinical trial. And we are hoping that the CAR T cells, again, are gonna do their work by identifying and destroying these autoreactive B cells that we believe are causing the disease. Another thing that is really important to mention, the same way the cell therapy is being hanging around for at least 100 years in different ways, CAR T cell therapy is not new to science and not new to even clinical practice. So patients, particularly with blood tumors, blood cancers, have been treated with CAR T cells for quite some time already. And we have a lot of accumulated experience on the use of this kind of treatments for patients with different kinds of malignancies. And as you can see here, this therapy has really revolutionized the field of hematological blood cancers. And a lot of patients have achieved remission and even long-term remission after failing several courses of chemotherapy. And a lot of these patients have been able to be cured from their cancer. Okay, so this is another picture that kind of goes over exactly all we have discussed so far. So again, we re-engineer our T cell. Now it's called CAR T cell. This CAR T cell has this new molecule, this new last name, and this molecule interacts with the CD19, this protein that hangs out from the membrane of the autoimmune B cell. And by doing so, it's basically killing the autoreactive B cell. Because this interaction is so specific to the CD19, and CD19 only exists in B cells, we believe we would avoid having fire or having destruction, having inflammation caused by CAR T cell to other tissues. So these other tissues that we have in our bodies, because they don't have, again, that very specific last name that is important to identify in B cells, the CD19, they won't be a target for the CAR T cell. We need to talk about side effects as well. Again, it seems very exciting. The biology makes a lot of sense. We have great experience when it comes to blood cancers, but we also need to acknowledge that some patients experience side effects. And I want to dedicate some time here to talk about this. The most common side effect, it is what we call cytokine release syndrome. Remember I mentioned to you the cytokine is just a fancy term for specific chemicals that our body produces that engage in inflammation, cause inflammation, propagate inflammation. That's exactly what it is. In the process, when a T cell and a B cell connect, that destruction can cause a lot of inflammation. And depending on how many of those autoreactive B cells we have and in which organs they are as well, that destruction can cause a lot of inflammation, can cause patients to be extremely inflamed, and they basically can behave with, they can present with mild fevers, chills, or can even cause this inflammatory response can be even more severe. And some patients have some inflammation in their lungs, inflammation in the kidneys, in the liver. So this is something that patients need to be monitored for. Some patients may develop this event called immune effector cell-associated neurotoxicity syndrome, ICANS. This is by far the most concerning short-term side effect related to CD CAR T cell therapy. Basically, this is a response that happens, and again, in the interaction between those B cells and T cells, we believe that it can be associated with neurologic manifestations. So some patients may develop some dizziness, confusions, or even seizures. The good news that I have for you is that we have treatment for both cytokine release syndrome and ICANS. We have nowadays wonderful medications. And again, remember I mentioned, we have a lot of experience in treating patients with malignant cancers. So we have medications that can be extremely helpful in treating. And we know also how to identify the earliest signs of cytokine release syndrome and ICANS and intervene upon it. The other good news, and again, I'm not going to disclose a lot of details, but Cabaletta has treated a few patients already with autoimmune diseases, some of them with myositis, with their product. And I can say safely that most of these patients do not have neither cytokine release syndrome or ICANS, which is really good news. Some of these patients can develop, particularly in the first few weeks after they receive the preconditioning. They receive the chemotherapy and they receive CAR T. They are at increased risk of infections. And at least in the cancer literature, we don't know yet about our autoimmune patients. But from the cancer literature, there are some concerns that patients may develop secondary cancers, particularly lymphomas. We don't know if that's the case for patients who have autoimmune diseases and will be receiving this kind of treatment. This is yet to be investigated, okay? Okay, now we talk about biology. We talk about what is the procedure related to the CAR T cell clinical trial. Let's talk a little bit about the Cabaletta clinical trial. So first of all, who is eligible for it? Who should be considered for this clinical trial? As I mentioned, myositis does not really differentiate according to age. Young patients and older patients can be affected. And the good news about this clinical trial is that patients from 6 years old to 75 years old can be enrolled. Patients, in order to be enrolled, must have active muscle weakness. So again, the myositis is active enough that the muscles are inflamed and they are weak. They are having difficulties raising from a low chair, washing their hair, because the muscles are being affected. Some patients as well, as part of the clinical trial with dermatomyositis, they can also have active dermatomyositis rash. It is really important to understand this is not a first-line treatment for patients with myositis. Thankfully, we do have patients in our practice that do respond to standard of care, and that's great news. But in order to be eligible for this clinical trial, most patients need to have used at some point treatments that are considered to be standard of care for the treatment of myositis. Things such as methotrexate, mycophenolate, hydroxychloroquine, or even rituximab that I mentioned before. It's not all kinds of myositis they are eligible for this clinical trial. At this point, Cabaletta is enrolling patients with dermatomyositis, antisynthetase syndrome, immune-mediated necrotizing myopathy, and juvenile myositis. I get this question a few times. Doctor, I have polymyositis and don't read polymyositis as one of the myositis they are being considered for this clinical trial. I request that you discuss that with your rheumatologist, and you can consider revisiting your diagnosis. Nowadays, we understand that a lot of patients had been diagnosed with polymyositis several years ago. As we learn more about myositis, they are being reclassified as having one of these other types of myositis. Patients are required to have some antibody related to myositis. And this is, again, something that you can discuss with your rheumatologist. They will let you know what kind of antibody that you have. That, again, it is important for the understanding of what kind of myositis you do have. And then patients with juvenile myositis are also required to have myositis-specific antibodies or other types of myositis associated antibodies as well. Again, those details need to be figured out because, again, this is a very concise review about who could be eligible for the clinical trial, but I'm sure the rheumatologist who is familiar with this protocol can help you understanding your eligibility to this clinical trial. Basically, again, this is kind of like a summary about what we discussed. The CABA 201, it is the product of this CAR T-cell clinical trial offered here by Cabaletta, which is the molecule that I mentioned to you that is inserted in those T cells, and these T cells are the ones that are being reinfused in the patient, okay? And as I mentioned, these cells are, again, modified in laboratory, they're expanded, and they are reinfused in patients. And we are hoping that these re-engineered T cells are the ones that are gonna carry through in targeting the autoreactive B cells that we believe are causing the inflammation related to the myositis. Okay, again, another summary, and this is just a nice schema on kind of like the timeline related to the Cabaletta clinical trial. Again, initially we need to identify patients with that could be eligible for the clinical trial. Patients undergo the leukapheresis, which is the blood transfusion we talked about. After that, they go through the preconditioning, that's the dose of chemotherapy to prime their immune system to receive the CAR T-cell clinical trial, the CAR T-cells. And then on day 1, they receive the CAR T-cells. After that, we follow these patients closely, particularly in the first few weeks. And our main endpoint here that we are very interested into, it is trying to understand how safe these procedures are for our patients with myositis. So we follow very closely for any types of adverse events that could come with this treatment. And these patients are followed through a few years, okay? Initially, our follow-up visits are very frequent, but as patients continue to move on through their clinical trial and things are proved to be, evolving well, these visits are spaced apart. And again, we are hoping that will continue to be the case throughout many years after the infusion of the CAR T cells. What to expect from the clinical trial. Again, it is really important to understand that this trial requires commitment, okay? This is what I tell my patients who are interested in this trial. We are talking about coming to the hospital, going through several kinds of tests, blood tests, specific kind of forms that need to be completed on a regular basis. The screening process is a long one because we want to make sure that we identify the right population for this study. The apheresis, as I mentioned, is a pretty standard procedure that looks very much as a blood transfusion. And then the CAR T-cell therapy preparation and infusion is followed by very rigorous monitoring. You're going to be in the hospital for a few days, depending on how things evolve, probably about 4 to 7 days. And then after that, we have close follow-ups. They're again spaced apart as patients evolve in their timelines of the clinical trials. If you are interested, or if you know someone, you're a caregiver, and you know someone who will be interested in this clinical trial, don't hesitate to contact the Cabaletta team. They're extremely responsive. They're very helpful, very nice people to work with. And you can also touch base with me and my research coordinator as well. We have received referrals from all over the country, and we are very happy to review those requests. And our team will work with you to make sure that you are the right candidate for this clinical trial. And we'll work with you to bring you to our center to be screened for the clinical trial and to be treated. Cabaletta will provide, again, financial support for the procedures related to the clinical trial, including travel, lodging related to the clinical trial. So this is something also important to acknowledge. Even though you may not have the means to travel somewhere, if you're eligible to this clinical trial, Cabaletta will be able to offer that support so you can have the right treatment for you. I think I finished. Hopefully there will be time for questions. I'm gonna stop sharing my screen and open for questions. Thank you.
Thank you, Iazsmin. That was great. Thank you so much for walking us through what CAR-T is and really starting off from what is even a B cell and a T cell. So that's great to bring it down to that level of detail. There are several questions in the Q&A. So I'll start, and most of them were submitted actually in anticipation of the meeting. So I'll start reading some of this, if that's okay with you.
Yes.
Okay, so how does this treatment, how would it differ from rituximab infusions from your perspective? How do you explain that?
This is a very good question. I think this is actually a research question, right, Tanya? This is something we want to find out. So again, the rituximab is also targeting these B cells. Some patients respond beautifully to rituximab. Some patients don't. The hypothesis behind this, and again, I'm saying hypothesis because this is really a research question at this point, is that the target of rituximab, the CD20, not target a specific group of individuals within the B cell family. It doesn't target the family overall. And because it targets individuals in a specific stage of their development, the rituximab may miss important cells that no longer have the CD20 in their membranes, and they may be autoreactive. So this is one of the hypotheses. The other hypothesis is that the rituximab may not be reaching all the sites where these autoreactive cells may be hiding. So we believe, this is all hypothetical, but we believe that the CAR T cell therapy would get to niches where the rituximab may not reach. So so overall, our feeling with the CAR T cell therapy is that it is probably targeting a wider range of family members within the B cell family, and also targeting specific niches that rituximab wouldn't reach.
Thank you for that, Iazsmin. There are several questions that I've answered already directly, but there's a lot of interest from the IBM community. So I really wanted to acknowledge I understand that there's such an unmet need, and I just wanted to, I think if you want to reemphasize the populations that were included in the RESET trial, and then maybe perhaps I can answer why at this moment we're not including IBM patients.
Yeah, so we don't, although IBM is a type of myositis, and we appreciate the possible autoimmune background related to IBM, it seems that the drivers of IBM are a little different than the ones that we see in antisynthetase syndrome, dermatomyositis, and immune-mediated necrotizing myopathy. It is possible that those B cells may not be as important in the pathogenesis. Other cells may be the ones that are autoreactive. So it seems that the mechanisms behind IBM may be a little different compared to these other myositis. That's the reason why IBM is not yet a target for CAR T cell therapy.
Yep, perfect. We covered it well, why we are not including, and it's exactly that. It's not that we want to forget anyone and not serve population of patients. It's really we're going with what we know from the biology at this point. Another question, and I think this is a helpful question. CAR T cells kill the autoimmune B cells, which is correct. And what happens to the cells after? Do they get replenished with normal B cells?
That's what we're hoping for, right, Tanya? So
yes.
it seems that's the case. Again, we have some case reports of patients who had been treated for about 2-3 years now. They have been followed closely in places such as Germany. And it seems that the bone marrow, again, remember those stem cells, the parent stem cell, later on the bone marrow kind of repopulates those B cells. And we are hoping that this repopulation, this new population of B cells, it is no longer autoreactive. So it's no longer causing the disease. Ultimately, that's the goal. We want to destroy the ones that are pathogenic, that are causing the disease, and we're going to allow space for new B cells to develop without the autoreactivity.
Thank you for that. I think another question, and I think you mentioned it in the inclusion criteria, but just to emphasize that patients with juvenile myositis could be included in our trial potentially.
Yes, and we actually one of the first centers.
Yes, we are.
Yeah, we are the first center to offer the juvenile the CAR T-cell therapy with Cabaletta for juvenile patients. And yes, and a lot of times, again, some of these cases can be very challenging to treat, even with very aggressive treatment options. So children may be the ones who can greatly benefit from this treatment, we hope.
Thank you. I think there are a few questions about the preconditioning in terms of the cyclophosphamide and the fludarabine, and because we refer to them as chemotherapy, but perhaps if you can give your thoughts about the potential for what is known about chemotherapy in general, of losing hair, feeling nauseous, and all those potential side effects.
Some of you may be familiar with cyclophosphamide. This is a medication that is used quite often in patients who have aggressive types of autoimmunity. Lupus, systemic sclerosis, myositis, we use very broadly. When patients fail many types of treatments and the disease is still very active, we quite often use cyclophosphamide. But usually when you use cyclophosphamide as standard of care in patients with myositis or autoimmune conditions, these patients have several infusions over the course of several months. Here we are talking about one infusion in combination with fludarabine. Nausea, it is a potential side effect. I think it is common during the infusion period, but I'll be very honest, and I have used against cyclophosphamide often throughout my years of career. Most patients tolerate it very well. We don't usually see hair loss in this patient population. We really don't, especially with just one infusion. Again, I'm talking about patients who would otherwise receive several months of chemotherapy for their autoimmune diseases. So it's usually very well tolerated. The main adverse event that we need to look for is because after 2 weeks, usually after they receive the chemotherapy, we need to monitor their cell counts. So their cell counts may lower a little bit, and we need to monitor there. It's quite rare that we need to intervene. Most of the time, it's just close monitoring in patients again, and after those 2 weeks, the cell counts recover back. So again, it is the name chemotherapy has a lot of burden in it, but I just want to acknowledge that a lot of our patients with refractory autoimmune conditions, including myositis, rely on much longer courses of chemotherapy with cyclophosphamide.
I think there's a few questions specifically about the study design, but one that pops at the top is, do subjects that participate in the trial have to stop their current treatments? And this is very specific to our study, right? So we can't generalize to other protocols, but Iazsmin, if you can mention perhaps your perspective in terms of the medications.
Yeah, so the protocol, again, gives a lot of details on like when to stop, but most of the time we hold the medication a little bit just before the leukapheresis. So just before the patients go through their blood transfusion, and when their T cells are being collected, we may hold their medication for just a little bit before that. And then after the leukapheresis, until they're ready to have the T cells reinfused, patients can continue their treatment. We are hoping with the CAR T cell, this is one of the goals, that eventually you won't need treatment anymore. So these medications, these immunosuppressive medications, we are hoping they will be able to discontinue those as you respond to CAR T cell therapy. But again, most of the time patients can continue throughout until the moment they receive the infusion, with a little bit of tweaking on their medication just before the leukapheresis phase.
There's a few other questions.
I have a question for you here. Some Canadians are asking if they're eligible to the trial. I don't know the answer to that.
Yeah, so at this point, and we just added on the chat in the webinar chat, the contacts for all the locations in the US. At this point, most of them are in the continental US. We do have listed a site in London, but the site is still not active. So at this point, unfortunately, at this point, all our sites in the US, there are sites that perhaps could consider patients that are out of state if there's not a site specifically close to.
Can a patient from Canada travel to the US?
That's a question that probably will be best answered individually by each site. Generally, we're staying within the continental US, but I think the best way to answer that would be directly with a site if they feel comfortable with it or not.
Mhm.
I saw this question. There's a question as well about inclusion criteria in terms of autoantibodies and other questions in terms of oxygen requirements. And I think at this point, the best way to determine eligibility and what we've been telling interested participants is to reach out to a site that's of their preference or close, because that would be best to evaluate their clinical records and really give an informed opinion in terms of eligibility for the study.
Yeah, autoantibodies in myositis is a very complex topic. So really advise that you discuss that with the site that you were interested in enrolling or with your rheumatologist.
I think we covered most of the questions that we have time for. Rachel and Linda, you let me know if what other housekeeping items should we take care of here. And again, Iazsmin, thank you so much for your time and going over the study design and CAR-T.
Oh, thank you, team. It's been very nice working with you, truly. I think you have a wonderful team, and we're excited about this opportunity. We all have come across several patients who really need something else than we can offer nowadays, and the CAR T cell therapy may be an interesting option for them.
Thank you. So Rachel, if we want to emphasize, perhaps I know we've been putting it in the chat regarding where they can find the future recordings of the session.
Yes, we will have that on our YouTube channel, and I believe Linda has or will put our YouTube channel in the chat. We typically put our webinars on the first of the following month. That it's January 28th. That's kind of a short turnaround time for me, but I think I can do it, and that's my goal. So we will get that out to everyone. And we do have about 10 minutes left if there are any other questions, but if all the actual CAR-T webinar questions have been answered, you're free to do your close. And then I will roll the webinar outro.
I think there's another question. I just saw it in the chat again about the sites, and we'll put all the information again in the chat in terms of where they can find the contact information for the different sites that they could reach, the interested participants can reach. Really, Iazsmin, I want to thank you for your time and for really explaining a very difficult topic in a way that can be easier to understand. I want to extend our deepest gratitude to all of the participating in this webinar and also all our future potential participants. And I know that some of the sites have already been treating patients. So really, we're very thankful for this community that is has so much passion and so much and want to advocate so much for themselves. So really, really thank you. We hope that you found today's session informative and that it has provided you with a deeper understanding of what we're doing with CAR-T in myositis. Special thank you again to TMA for hosting this event and for letting us, Cabaletta Bio, to sponsor the webinar. We are really committed to helping advance the knowledge and potential treatments for myositis patients. And on behalf of TMA, Cabaletta Bio, and Dr. Ventura, I want to thank you again for your time, your engagement, your questions, and the continued support of the myositis community. We hope to see you again in a future event. And until then, take care and stay safe.
Ciao, everyone. Take care. Good evening.
Bye, everyone.